maybe to bring people a little bit up to speed for everyone who joined new, while others are still signing up. This discussion, or generally what this group is, it's the Foresight's Health Extension Strategy Group. It was created after we initially launched with a few kind of like in-person investment salons in San Francisco that was sponsored by 100 Plus Capital. Then, of course, COVID hit, and we had like our last meeting in person just before the lockdown occurred. And then we had like immediately with the lockdown, we started like a week of 10 weeks of a daily online salon, and that was focused on opportunities from COVID to accelerate different technologies that we care about, or to generally have positive pathways into beneficial futures. Aging was obviously one that came up a lot. Meanwhile, then we thought maybe it's really good to just have a coordination arm for those people that are already working in the field, because I think if there is one subject that should really, I think, be accelerated post COVID-19, then that is the topic of aging, really, and I think it should be really on people's minds, and it should be a no-brainer, but still it requires a lot of coordination to do that. And this is now, I think, the fourth meeting in this row of our Thursday/Friday meetings, where we all meet and try to coordinate on a different topic. And this particular meeting came about because at last week's meeting, we basically, Aubrey was there, and Jim O'Neill was there, and a few others, and we basically discussed what are different strategies right now that could be appealing to policymakers, and try to compare strategies there and what worked. And then we kind of spiraled into a long discussion on Singapore towards the end of it. And Louise was there, who gave some really, really fantastic insights into what's working well and how the Singaporean model works, and maybe what could be ported to the US and what couldn't be. And then afterwards, I followed up with Louise, who then put me in contact with a few of you. So thank you so much for joining, and for joining in the morning for you, especially to Brian, Shazib, Swaine, I think, if you're here, Louise, and then we have Margareta as well. And so thank you so much for taking time and for doing this so spontaneously. I will try to say very, very little today, and I think Lou can maybe even, Louise, if you're willing and able, you can maybe onboard people much better to that kind of like intersection between trying to learn from different models on aging strategy and funding and policy, what works. So perhaps, Louise, you could bring the speakers that you onboarded here up to speed on a little bit on the context of why we're discussing this today, and then we can launch into a conversation. For now, I want to say thank you so much for joining us. I'm going to post a little bit more about you and links to your organizations in the chat here, but I'm really thrilled that you made it. Welcome.
Thank you, Alison, and good morning, Shazib.
Yeah, thank you, Alison. So I'm not going to say very much either, because we have some great talent, some great minds from Singapore who understand the landscape much better than I do. I'm going to provide an entrepreneur's perspective on why I love Singapore and why I'm digging deeper into that intellectual ecosystem. So I was one of the entrepreneurs in residence at the Buck Institute back in 2016, 2015, and got to know Brian there. And we had a number of just free-ranging discussions about the future of science and healthcare. And when Brian left the Buck, and also I was talking a lot with Raja Kamal, who's a PhD in policy, government policy, and there was a sudden shift of emphasis to Singapore. And the reason was, I think, and I don't want to put words in Brian's mouth, but the sense I had is that Singapore is a meritocracy. It's a meritocracy of talent, and it's a meritocracy of ideas. And it's also a concentration of power in a relatively small number of hands in terms of finance, government, science, regulatory approval. Things can happen very, very quickly there. There is still bureaucracy. There still are missteps, but they learn from their mistakes. They don't seem to make the same mistakes over and over again the way we do. So I was kind of recruited by Raja to join an organization called the NIC, which I highly recommend. And it stands for National University of Singapore Medicine International Council. And what it is it's a group of international thinkers, policymakers, entrepreneurs, who pay a fee, and it's $10,000 or $15,000 a year, something like that. And you are ushered into a community in Singapore that includes a lot of the talent at NUHS, National University of Singapore. You have a lot of government officials. There are programs and presentations involving top government officials that come in from other countries and talk about what works. But what's amazing about the NIC program is the entree and access you have to talent within the Singapore Brain Trust. And it's not even really dependent on the NIC. The NIC is sort of a doorway. And once you get to know these people, they're incredibly welcoming of new ideas, innovation, and you start to learn from them why Singapore works, why it's an extraordinary success story. It's consistently in the top 5 rankings of national healthcare systems, some of which is portable to this country and some of which is unique to the circumstances in Singapore. So I'm going to post some links at the end of this discussion. There's a very good article in the New York Times in 2019 on what is special about Singapore, what works, what we could learn, and what maybe is unique to them. There's also some very interesting government documents that lay out very clearly the priorities of the government, which is kind of a guiding light. Clearly, the results are stemming from clear government policies. And also, the other thing you learn when you visit Singapore, and I've been there several times, is that they are constantly iterating, constantly tinkering to make it better. So it's not ever really done. That's the sense you get. They've been just so welcoming to us. In fact, we just found out a few days ago that one of the researchers in Singapore applied for a 6-figure grant from the medical school just to collaborate with us. And within a few weeks, they were awarded this grant. So things can happen quickly. And even if they don't tangibly result in funding, they tend to result in great ideas and collaborations almost immediately. So with that, as far as maybe since I was brought into the Singapore community first through Brian could maybe speak next. But I also want to say that through Brian, I met Shazib Pervaiz, who's an MD, PhD in aging as well as in cancer. And both of them have become my good friends. And my new friend, Swaine Chen, is on the line as well. He's leading the collaboration that we're going to be engaged in. And I think all of them should, at this point, take over because they know a lot more about what's possible and not possible there than I do.
Fantastic. Thank you so much. Brian, would you perhaps care to start? I just shared a little bit on the background on you here in the chat, but it seemed from the last conversation that most of the people have either known you in person or at least were very familiar with your work. Welcome.
Yeah, I'm notorious. Yeah, I think that maybe what I can do is give you a little bit of a feel for what's going on in aging in Singapore. And I think fundamentally, the challenge here is threefold. One is the demographics. The population is aging quite rapidly, such that about 38% of people are going to be over the age of 65 within the next decade. And that's due in part to a low birth rate, long lifespan. And the other thing that, you could say that about Japan and Korea as well, but the other thing that makes this different is we're on a small island here that is really, depending on your frame of mind, saturated in terms of bringing new people in. So one strategy to mitigate an aging population is immigration, because young people tend to come to countries and want to work. That's not easy to do here because it's hard to put more people in Singapore. So they're looking at a situation where they're only going to have 2.1 workers for every retired person in 10 years. And I think that's what's motivated the government to really focus on aging. So they've set aside a significant amount of money to try to tackle the aging problem. And one thing the Singapore government can do is that the US government really can't, is to think long term. And the same party's been in power for forever. And the elections are coming next week. I don't expect much different to happen. But they are thinking 5 and 10 years ahead because they can still reap the rewards of the programs they start because they're likely to still be in office. And I think that and the fact that even though Singapore is a democracy, you have one party that stays in power for a long time. It's pretty much the government here is as close to benevolent as you can get. I think that they really look at policies to try to improve the plight of the population here. Sometimes I think they could be more risk-taking and more innovative, but I think in general, they've done a very good job of bringing technology into Singapore. So this is a really high-tech space. And just to give you a feel for the healthcare system before I stop, the government does pay a lot of the healthcare for the population, so it's very different from the U.S. in that perspective, in many ways. The healthcare system is quite good. The public healthcare system, for instance, we have under 30 people who've died from coronavirus. Even though about 40,000 people have been infected, and there have been some good strategies and missteps around controlling infections in Singapore, but the care people have gotten once they get infected is probably among the best. And so the healthcare system in many ways works well here, and the costs though are spiraling out of control because of the aging population. So if you're over 65 and you're disease-free, it costs you under 2,000. The cost for you is under 2,000 Singapore dollars a year. If you have 2 or more chronic diseases, you're at $15,000 a year. And so the idea of slowing aging to keep people healthy, keep them disease-free, is something that's very appealing to the decision makers in Singapore.
Okay. It's great. I think I'm just writing in the chat to collect questions here because I'm sure that there's a lot of threads where people would like to go into a little bit more detail on. Shall we say, maybe we can just do the opening remarks first, and then we'll just launch out into a wide discussion just to get everyone a little bit of a background. All right. Okay. Thank you so much. And then would Swaine maybe like to go next, or?
Hey, hello. Thanks for the opportunity to join this conversation. I'm super excited. And I was going through the notes from last one. So this is the first time I'm trying to sort of catch up and get up to speed. Maybe I should introduce myself very briefly. I'm not an aging researcher, actually, but I specialize in infectious disease. So I think saw Allison sent some links about some of my background and some of my media presence. So obviously, infectious disease, we've been heavily involved in some aspects of the COVID-19 response here, not directly in the front lines, but just, there's been a huge demand for people that have infection expertise. My main expertise from research point of view and from my training is in bacterial infectious diseases. And so that interplays a lot with another huge problem for healthcare, which is antibiotic resistance, which I think is probably, among the sort of big problems that we have looming in the future. Antibiotic resistance, aging, these are all sort of, at this point, appear to be about the same size. So I don't want to say too much, since I know this is supposed to be about sort of aging and sort of looking through the notes. I can see that there's a lot of connections, however, in terms of these questions about how to advocate and how to sort of get unity behind certain things that behind policies or government-wide, nationwide efforts to tackle these big problems, which is really needed. And so I'll just say that, one of the things, like, I'm an American, I was born and raised in the US, and I moved to Singapore about 10 years ago. And so I missed SARS, fortunately. I was not here during the SARS pandemic, but then now I've been here and seen the entire COVID-19 thing. And it is true, I think there are many things that changed with COVID that I think looking at the notes from last time may be relevant for how to advocate for aging, or how to sort of make things change if you want to actually get policy and decision makers to get on board. So I would say that, Brian and Lou already mentioned a couple of specific things about Singapore. COVID-19 certainly was a huge event. I mean, even within Singapore, it's a small country. There are some silos. There are, different universities and different research institutes and different government agencies and centers that at an academic level, sometimes, there's a healthy competition, I would say. And COVID-19 was really significant in immediately knocking all those barriers down. There's an immediate organization, and kind of everybody fell in line and got on board with the national response. And I think, those are why you see these numbers where only 30 some people have died from COVID-19 despite 40,000 cases, and the ability to just mobilize the entire healthcare system to tackle testing plus isolation plus contact tracing, right? This happened extremely fast and happened across all institutes immediately, just because they needed people, right? And I think these are maybe some things we can sort of launch into discussions as to why does that work in Singapore? What was unique about Singapore, or what was unique about COVID-19 that we could learn from, that then we could apply that to other areas where you want to get that kind of coordination and alignment. And maybe I'll just leave my comments there for now. Thank you. Thanks again for bringing me in on this, Lou and Allison.
Fantastic. Thank you so much. And then perhaps we could have Shazib as well. Welcome, Shazib.
Thanks, Alison. So good morning to everyone. So let me introduce myself. I'm Shazib Pervaiz. I'm at the Faculty of Medicine, and I moved to Singapore almost 24 years ago from Boston. And perhaps I can maybe give you a little bit of a background what I do and what's its relationship to aging. And then perhaps maybe I'll take the liberty of maybe following up on what Brian mentioned and give you a little bit of historical perspective on Singapore, because I've been here for perhaps the longest of all of us here. My area of work is in cancer biology, but there are cellular mechanisms that I work on which cross talk with research on aging and understanding mechanistic biology of aging, particularly senescence and inflammation. But my area of expertise is in chemotherapy, resistance, and redox biology. Now, with respect to aging, I mean, it's been awesome to have Brian around and been working very closely with Brian, and we learned a lot in terms of the biology of aging from him. I mean, as Brian mentioned very rightly, Singapore is a very small place, about 715 square kilometers, with a density of population of about 8,000 per square meter square. I mean, that's a very, very concentrated population, and most of us live in high rises here. The population is expected to be about 900,000 by 2030, over 65. And the problem here is that the fertility rate is about 1.2, as opposed to the replacement rate of 2.1. So the US differs from us in that, because the US can still maintain that 2.1 replacement factor, because their fertility rate is higher than what we have in Singapore. So the Singapore government, as Brian mentioned very rightly, and Lou also alluded to it, were actually at this about almost 40 years ago, when the first commission on aging was put together in the 80s. So this is something that is something that they thought about way too far ahead. And it's in the 80s when they actually put together this idea that there should be integration of the elderly in the society, in families, and then basically based on the Confucius mindset of filial piety. And then over every decade, you saw this thing move forward. In the 90s, they put together this concept of successful aging. Aging in place was a concept. And then during the 2000s, there was a real drive on city for all ages. So the idea was that you need to integrate such that you have intergenerational living. Elderly people are not just left to do things by themselves. There was focus on bringing them together with family, society, and then the role of the state in this. And so the Singapore government in 2009 onwards then put together some structures in place to actually address the issue of accessibility, transport, housing, and gave this concept of the active aging hubs, and put together $3 billion to set aside to start working on these initiatives. And the one big initiative included in that was active research, and then fostering research and collaborations on various aspects of aging, from basic cellular to all the way to societal issues.
All right, lovely. Okay, so I think we have really good opening remarks. I think, Luis, feel free to, definitely take it where you'd like, but I think to kind of like pick up where we left it at last week's meeting. So I think, Brian, what you mentioned at the beginning, that the Singaporean government can have a much longer term view, right? This is obviously not really the case for the US, and especially, and that has to do also something to do with electoral cycles, right? So because it was very interesting initially, I think someone had mentioned, well, it would just be quite interesting to see which companies could maybe able to move to Singapore. That may not be a bad strategy, and I think like you many of you would agree. But then last week we talked a little bit about what what characteristics, if any, are portable to the US system. And so here is one that you just mentioned right now, right, which is the electoral cycles that and the ability to plan a little bit more long term for the Singaporean government. So are you hopeful that there are any, can you pinpoint any specific, and that goes to all of you, any specific characteristics where you think that those may actually be tweaks that we could make in the US rather than really requiring an overhaul of the whole political system?
Yeah, well, for one thing, I don't want long-term long-term power for the current political system. I think that leaving the president in charge for 40 years may not be the way to bring U.S. closer to Singapore. I think that there are some fundamental differences about Singapore that are a little bit, and I've seen this very clearly in the COVID-19 response, that are very different from the U.S. I mean, you have a government that can galvanize the scientists and the medical professionals from different universities, get them to work together. So you have much more a unified response, whereas in the U.S. you have 50 states doing different things, and states share power with the federal government, and that can be challenging in a crisis response. I think that also there's more of a, I really, and I've been here only about 3 years, I think that one thing I notice is there's a lot of national pride here. There's more respect for the government than there is in the U.S. And so when it comes to, and there's more enforcement too. So when it comes to something like a lockdown, people do what they're supposed to do. They don't ignore it. And if they do ignore it, they get fined. Or if you're a foreign work permit holder, you might get sent back to your country. So I think that there's more of a community view here as opposed to an individual view, and that has its drawbacks too. But in a crisis response mode, I think it's an advantage. And I think we can apply that to aging here too. I look at this as a test bed for interventions to slow the aging process, because the clinical trials are hard to do here, just like they are in the US, but it's probably easier to scale successful clinical studies into community-based strategies to slow aging. And that's one of the main reasons I came here. Right now in the US we have a lack of leadership, but maybe I'll just comment more generally about the issues. I think that the reimbursement system in the U.S. on healthcare is an interesting challenge. And this is one of the reasons that pharmaceutical companies have been hesitant to go into aging. So a good thing about the U.S. is the private sector and venture capitalists, private investors have now really started engaging the aging ideas around aging. And so we have a lot of new companies starting in the aging space, trying to do all kinds of different things. And that's better in the US than it is here, I would say, at the moment. But there's still sort of the 600-pound gorilla in the room, which is that how do if you have an intervention that slows aging, how do you make money off of that? Because FDA doesn't consider aging a disease, it's not reimbursable, and changes are happening there, but they're slow. So, I think that a government system to really target healthy aging is needed right now, at least until a transition can happen and we can get people to recognize the importance of aging in keeping people healthy. But having a government that can put money into challenges that are coming up is something that's very important. So even if you look at the NIH, it's very siloed. And there was this thing called the Geroscience Initiative put forward by the National Institute of Aging to try to get the other institutes to realize that aging is a big problem for them. So NCI, cancer, for instance, aging is the biggest risk factor. Infectious disease, aging is the biggest risk factor for complications. And that goes right across the different NIH institutes. And everybody was on board. There was a lot of interesting discussion. And then when it came to other institutes putting money into aging research, everything halted. And so you have this very disease-oriented approach in the US. And I think the best thing the US could do is to try to refocus on healthcare as opposed to sick care, which is what they're doing now. And that's something that is a big challenge to get a big change to try to get to happen. One way to do that is to rethink how you pay physicians, because right now they're paid on procedures, and maybe we should look at compensating medical professionals based on keeping people healthy like some other countries do, because that, although it also has some challenges, refocuses what the goal of the physician is to try to work with people earlier to keep them healthier. So
Does Singapore do that? Does Singapore do that?
Not really, no. But the reimbursement system is very different in Singapore. It's not strictly, I want to do as many MRI scans as I can because that's how I make most of my money. So, but there is some element of that.
Or as many coronary bypasses. Hey, I have a question, if people don't mind. This is kind of both a COVID question and a Singapore healthcare question and a Singapore population question. There's been some chat on the side channel on this, but for the people who actually know about the Singapore health system and the Singapore health statistics, I'm wondering, what is the general health of the population? What is the lifespan of the population compared to other countries? Do you think that's been part of what has made the very small case fatality ratio in COVID, not the slow spread, that's, societal, procedures and stuff, but like this low fatality ratio, how healthy is the population? How much does that matter for COVID? How much does that matter for aging? And if it's good, what are they doing that we can learn from in the rest of the world to keep their people healthy? Because there's no point really in even, in my opinion, even talking about COVID or talking about aging if everybody's unhealthy to begin with.
Yeah, maybe I can jump in. So it looks like in the chat that some of these ideas about lifespan, I think Lou's providing a lot of good information here. It is one of the best healthcare systems in the world. One of the things that was hinted at early on that Brian mentioned was there were maybe some missteps or some pockets of transmission for COVID-19 that weren't caught early on. And so in reality, Singapore's 40,000 cases, they actually report those and from an outside point of view, they report those in a somewhat strange way because they report them kind of based on your immigration status. And the vast, vast majority of the 40,000 are actually what they call foreign workers here. And those are people who are, many times working in manual labor. They're living in sort of dedicated facilities. They're very high density housing. I mean, Singapore overall has high density housing, but those tend to be very young people. And it's sort of doing manual labor. We sort of assume that the cardiovascular fitness is quite good. And so I would say that one of the reasons for the Singapore fatality rate being so low is also, it actually is kind of related to the sort of systemic things that they've done to sort of slow spread, because they have picked up many asymptomatic cases among those foreign workers, and those contribute a large number of the case count. But they're just asymptomatic, and they're still spreading among, again, a relatively younger population. So despite the fact that, there's these different sectors of Singapore society, and so, of course, this conversation is about aging, there is this, they do call it this silver tsunami, the population is aging, but those foreign workers, that's a relatively large cohort of people. It's about 10% of the entire population here, or 10% of the entire sort of country's population is those kind of foreign workers. And they're in their mid-20s or something, right? So I think that also contributes, it contributes a lot to the case numbers, but they've caught many asymptomatic cases here.
But
And
probably,
then I want to just
probably not much to the fatality numbers, I would guess.
That's exactly right. And so that's why the rate is so low, because you've just increased the sort of N on the bottom. That's one of the reasons.
That's not the only reason. I mean, the rate's still low, even if you factor that out. And my sense is that and you can correct me if I'm wrong, my sense is that they do a much better job of handling healthcare of people that are symptomatic as well. So they don't.
Yes,
they don't tell you to go home and come back when you can't breathe. They monitor you, put you in a situation where they can catch complications.
Maybe an example. So this is stuff that's in the newspaper. It's not confidential information at all. What happens when you actually get a positive test in Singapore? Mm-hmm. And so, there's many things in Singapore that allow this to happen, right? It's a small country and everyone has digital devices, and you kind of, in daily life, you walk around in Singapore and you kind of give away the equivalent of your social security number all the time. Because, I mean, just the way their security and sort of fraud system is set up, it doesn't rely on that. And so what happens when you test is you get a text message and a phone call from the Ministry of Health, and they tell you to pack a bag, and in 30 minutes an ambulance is going to come pick you up and take you to an isolation facility where then you're going to stay, and you have your own place, so that while they're sort of determining what your real status is, and how intense care do you need to go to the SU, do you need to just be in a general ward, isolation ward, or do you need to go to one of these large facilities where they basically just keep people isolated, but they're not that sick, right? They're essentially asymptomatic. All this stuff, all the infrastructure, the government is basically put this in place, and within a half hour of a positive test, all those people are contacted and then shuttled off to someplace else, right? So they're catching it early, and then also triaging very quickly, like, what do you need to do with these people? And that helps them manage capacity as well, so that you don't have these issues where you don't have access to the care that you need. You don't have access to the care that you need based on the severity of the disease.
Okay, but that is, excuse me for interrupting one more time, I'll shut up after this. That is relevant to epidemic control and all this great stuff. Yeah, they do a great job on that, but there's something else that they're doing that's keeping the population healthy to begin with, so that even outside of all the COVID and all the isolation of asymptomatic people, that they have a low fatality rate and they have a healthy population and a long lifespan. And that seems more relevant to the aging question, frankly. And so I'm wondering if people could talk a little bit about what makes Singaporeans healthy and what can we learn from that?
Yeah, I think there's a great sort of set of questions to set up unpacking this idea that it's the healthcare system before COVID happened that's actually contributing to this. And so I'll also stop talking so much here, and maybe we can explore that idea. I think that's a really interesting idea.
Shazib or Brian, do you want to comment?
Yeah, maybe two quick points. One, a follow-up to what Brian mentioned, and perhaps what I think, being trained in the US and then came here, and I kind of know the system, how it works here very well. I think it's very difficult to draw parallels between a small city of 5.5 million people and comparing that to a huge country of 280 million people or more. Perhaps I think one of the answers to that question may be that it's very easy. I mean, I was right here smack when SARS happened. In fact, I was in the deanery and we had to deal with it. And that was our first experience when Singapore hadn't seen something like this of that scale. And that's where we learned a lot of lessons, and we were fortunate that we didn't get hit as bad as we were in COVID-19. But I still believe that in a small place like this, things can be very quickly mobilized, and you can put things in place and monitor them. It's almost impossible to do that in Europe or in the US. Perhaps what you could do is maybe do it at the level of the counties in the US. You know? You can even do it lower than the states, because the states are even too big. So there has to be a change in the mindset of how things apply. You can't expect the federal government to, of course, they have some responsibility of setting examples. But if they're not, and obviously the governor is responsible for whatever the state does, but then you have the mayors of the cities, and then you have the counties. So what Singapore can set an example is at the level of a small little county that can actually manage its affairs and not be dependent on the whole state or the whole federal government to come down with plans and with the guidelines that are very difficult to follow and enforce. And the second issue probably is that in the US, we are infatuated with therapeutics. We think that anything goes wrong with us, we just pop a pill and we'll fix the problem. Preventive medicine is still not there. People don't think that we can follow that. Perhaps the next generation might be following it, but if I read the MacArthur report, the results and their analysis are not very encouraging. What they're showing, in fact, is that there is compression of morbidity in the elderly, but our younger population is actually not as healthy as they should be. So you're going to end up in the next 20 years of having those 65-year-olds even worse than they are in the state today. So I think that's what needs to be addressed. Some emphasis, a serious emphasis on what Brian mentioned, less reliance on therapy and more reliance on healthy lifestyle, healthy lifespan, and perhaps preventive medicine. And that's perhaps what the Asian context is all about. Their diet is different. Somebody posted a comment in that Singaporeans love to eat. And yes, their food is not really very healthy if you look at it from the food courts that you go to. But somehow they are probably a little bit more active, I believe. Their lifespan is probably the best in the world right now. So there is something, perhaps the weather, being closer to the equator. But I don't know, really. You can't point a finger, because I don't see them really so healthy in terms of, well, they're always out there and they're doing things. But still, they are in a state where they are able to put that together in a small place with 5.5 to 6 million people. So I think it's very difficult to be able to dictate maybe a 1, 2, 3 that we can do in the US that Singapore is able to do and implement, or Denmark can do and implement, or Switzerland can do and implement, because there are small places with populations that are either very sparse or very concentrated.
I think just a comment on the diet, if I can here. I think that you have to remember there are three major ethnicities here, and a few others sprinkled in. So there's about 65 to 70% Chinese ethnicity, and then about 15% Malay and 10% Indian. And that's worth bringing up because the diets are somewhat different for these ethnicities. And I think that the diet for the Chinese population is probably certainly not as good as Japan, but also probably much better than the Western diet, even still. So there is probably a contributing factor of diet in terms of keeping people healthy. The diet for the Malay and Indian population is not as healthy generally. And so one of the things we're trying to do with our long-term aging studies is to tease out differences between these three populations to try to understand how lifestyle, diet, and maybe genetics contributes to different rates of aging.
Interesting. Okay, Keith, do you want to go with your question?
Yeah, basically following up on some of what Brian and Shazib were just discussing, and really to bring the conversation back to the prompt of what kind of learnings that we can get politically and how we can influence the U.S. directly. So one thing that stood out to me, Brian, when you were having more cohesion, it made me think that whenever I see the metrics for, the gray tsunami and the growing disparity in the demographics, I always see it at the country level. But now I'm very interested in seeing what those metrics are state by state in the U.S. to see if there are some states that are, especially worse than others. And maybe we can use that as a leverage point, because one thing that has been very effectively leveraged in the past for various policy measures to actually get them passed is to find some states where a pain point is worse than other states, and then in a sense convert that whole state and the governors and the mayors into like a stakeholder that is sounding like, why are these states okay and we're getting screwed? We got to fix the system. And then that becomes like a national issue. So well, do we have those metrics handy?
I think that demographic metrics are available, but I don't know all the answers to that. But I think there's a step before that, which is life expectancy. And that varies tremendously by state in the US, and it's generally linked to poverty. And I think that's another factor we have to consider in the US. We still have a large number of people without health insurance or with poor health insurance. The cheap food in the US has now become the unhealthy food. And so the socioeconomic status is very tightly linked to life expectancy. That's not really as much of a problem in Singapore. I think that there's more of a consistency in terms of socioeconomic status at the bottom, so that everybody has access to, or most people have access to, basic needs. And those numbers tend to bring down a lot of statistics in the US. This aging problem has a big component of poverty in it.
Well,
in the US.
I was just going to say, Alison, really quick, I don't think that's necessarily a problem. I think, again, that creates an opportunity to create more solidarity with economic justice movements. So that's all I was going to say.
I think we had someone who wanted to say something. I think Larry Callahan.
Yeah. Thanks, Alison. Yeah, I was going to ask a couple of questions. I mean, as far as the COVID, I mean, what sort of interventions? I mean, how many people got to the ICU? Did you keep them alive? I mean, in the U.S., about, there's estimates that 80% of the people get on ventilators actually die. And are you, is that because we don't have good pulmonologists that are monitoring it? Are you using things like ECMO more than ventilators that seem to have a lower rate, and are using any sort of therapeutics? I mean, because I agree that U.S. is way over medicated, what Shabazz said, but again, for infectious diseases, I mean, therapeutics sometimes are the answer. And are you using things like favipiravir or famotidine, which, I mean, is there a different formulary there that they're using? Hopefully they weren't using hydroxychloroquine, but, were they doing stuff? And then the other thing is, what are your medical health records like? One of the terrible things in the US is that we have terrible health records. So we can't really even tell what works and what doesn't work half the time. We approve drugs at FDA, but we don't approve medicine. And so, they, people are in 6 or 7 or 13 medicines when you get older, and you're taking medicines to mostly abrogate the side effects of other medicines. And I was just wondering how Singapore controls that to keep the health. I mean, I know some good physicians in the U.S. will never give anybody more than 6 medicines, but there's a lot of our elderly people that are on 30 medicines literally, and it's really crazy.
So I would only have some general comments. I don't know if Shazib or Brian have specific knowledge of some of these treatment stuff and then sort of polypharmacy here. I mean, I have some general comments I can make on that, but nothing too detailed.
Go for it.
Yeah. So I mean, I think in terms of COVID, in terms of the treatment, they did have the SARS experience and they were learning from that. So I don't think it's necessarily a pharmacy thing in terms of that we had different drugs here. It's not that we had different sort of technology. There was ECMO being used, but I think at a relatively low rate. But they had a lot of experience from the past in doing this, and that experience, fortunately, is still in the system since the SARS days. So I think that helped with kind of some of the management. Whereas, like in the U.S. and Europe, I think a lot of the ICUs were figuring out what to do with these cases as they were coming in, right? So they were sort of like building the plane as they were trying to fly it. in terms of the medical records, was another thing that I can comment briefly on. The medical records here, if you're in the system, you'll hear a lot of kind of complaints about the medical record as well, that it's not as organized, or, there's many things in Singapore that work really well, and they're trying to push towards a national electronic health record. And this is one thing that I haven't really been able to fully solve yet. However, that said, I think it's the internal Singapore's perspective. If you look at it from the outside, that medical record is much, much, much better than it is in the US. And also, there's all these similar issues that have been raised before. It's a small city, or it's a single city. The healthcare system is sort of well defined, and you basically don't lose people to follow up, or people don't go outside the system so much. So there's an interesting statistic along the lines of what you said, that basically Singapore has the highest rate of adverse drug reactions in the world. Okay, but that's a detection thing, because all this stuff gets reported, right? So Singapore is one of the best places to actually do some. There's a research project that's going on in my institute, which is looking at, because we have the best data in the world on adverse drug reactions and sort of interaction with other drugs, because the reporting is so good, right? So that does sort of play into this, and I think. I think there's still issues with polypharmacy, but again, that goes into like larger issues about the healthcare system, where if you sort of keep the population healthy, those issues would be a little bit less severe.
Can I add?
If you don't, go ahead, Shazib.
Can I add a comment on that? And I think I agree with Swaine on that, because what happened in Spain, for example, or in France, or in Jersey or New York, it is not that the people died because they were positive for COVID-19. It's because the system completely collapsed, because you were not able to handle, and it was overwhelming to the healthcare system. And a lot of people actually, unfortunately, died who could have been saved. So what Singapore did well was to make sure that when the lockdown happened, that their elderly and vulnerable population was monitored. And that is the reason why their mortality rate is so low. As Brian mentioned before, and you mentioned as well, the pockets of our infections were in the dormitories, and most of these people are 30, 35-year-olds. So even if they are positive, they probably will recover. And that is the reason why we only have almost less than 200 patients actually in the hospitals right now. Most of them are in other facilities that is outside. So total Singapore cases right now are about 4,000 that are admitted. And out of those 4,000, only 200 patients are in the hospitals, only one in the ICU, or two. So I think that was one of the factors that they did well to ensure that the vulnerable population and population with comorbidities, they don't end up in the ICUs. And if they do, the ICU and the system doesn't collapse.
There's one other thing that's happening here, though, that I don't know if the U.S. is ready to adopt yet, which is that now we have an app on our phone, and everywhere we go, we have to scan a barcode. Grocery store, gas station, whatever, have to scan a barcode to record essentially that we were there. And the government is using that as a means of trying to help you figure out where you were, so they can find people you might have come into contact with and quarantine them if you get sick. So that aids in contact tracing. But it also, has the potential to start to look like Big Brother, where people are monitoring where you're going and what you're doing. And I think that there's a general acceptance of this in Singapore and China, but I'm not sure how well it would fly in the United States. So that's another cultural difference.
Yeah, I was just going to point this out actually, and again, it ties back to what you said originally, right, about the kind of like one-party system. How do people on the ground feel about that type of political system, right? Because, or even you, right? Are you worried that this may flip? Are there any signs that this may go more into like the Hong Kong kind of like way, what we currently see, or do you actually think that it's working well?
I don't know. I can let others comment on this too. I think it generally works quite well, but there is more monitoring and than there is and it's more of a community first based strategy than an individualist strategy that you see so much in the U.S. So I don't have a problem with it personally, but maybe I can let people that have been here longer than me comment on that as well.
Maybe we can go up in the sort of Singapore history here in terms of time. So I guess I'm like the second longest in Singapore, and I think it works really well. I would say that, being born and raised in America, you when I first moved here, clearly you understand that there are different choices that the government has just made, right? And there are things that you hear that, as Brian alluded to, that as an American, I would feel very uncomfortable with. But like I said, after 10 years, I essentially give out my social security number. The Singapore equivalent of my social security number is just commonly given out, and it's not a privacy concern here. So maybe that's just because that's the level of monitoring. Maybe another example would be in 2017, the National Day rally. So this is an annual event that the Prime Minister is speaking to the entire country. They want to introduce a Smart Nation initiative. And he actually says, I want every lamppost to be a smart lamppost, which has cameras recording everybody that's going by, right? And we'll have sensors and Wi-Fi, and so that we can track all the motions of people. And, and this was a great thing that he was saying. That's the attitude here, right? And then I would say there's one other thing that, there's a point from before, but one other thing that I want to raise that, really gives you a sense of like what the difference is in maybe the US and Singapore that it impacts how much can be translated. And, one thing that people, I think it took me several years before someone finally told me this, or you sort of meet enough people. It turns out Singapore has a long-term planning committee, a long-term strategic committee. And what is strategic? It's not 5 to 10 years. It's not the next election. They have a strategic planning committee that's the entire length of, they're planning for the entire length of the existence of government. So they're planning 50 to 100 years into the future now as to what the government, what are sort of our sort of big strategic things that we want to do, right? And so this now seeds kind of, we want to develop biomedical sciences, which started about 25 years ago, right? This seeds, these kinds of things where we need to look at aging, or we need to control healthcare costs, or, here's the strategies that we're going to do. They have a 50 and 100-year plan for doing this in the Singapore government. And that's the kind of, difference in the sort of government planning that then leads to all these other things that they can sort of slowly, I think, introduce these ideas, slowly kind of, guide kind of attitudes in the public to move forward. And then if just one more thing, there's actually an interesting comment that I've heard several Singaporeans make to me that that because only one party is in power, and because they're stably in power, and no one expects that to change, there's some comment that actually Singapore is the most democratically responsive government of all, because they have to keep their pulse. There's no sort of mechanism at the election level. They have to sort of keep their pulse on what public opinion is. And they react, this sort of idea that Lou mentioned, that they're always tinkering and always sort of iterating. They are very responsive to what public opinion is. They've got grassroots movements, or they're trying to get the feel of what's going on the ground. So this is another system they have in place, this sort of, basically this idea of sustainability, not just for the government, but also economically.
Well, this planning committee is interesting. I would love to see, does anyone else know of any other country having instantiated that, which is not a more a one-party system? Because that doesn't necessarily require that it's in the government, right? As long as it kind of survives election cycles. And maybe a follow-up question that I had is, I would love to maybe go back to the point that we mentioned earlier of okay, maybe nothing in that model can be ported, to the US, and for good reasons, I think. But perhaps we should tackle more cities or even states, kind of that level, within the US. If that is the case, then how? Because I thought that most of the problems that in the US that always bubble up with aging are kind of the siloing of the national institutes, but then also on the other hand, the kind of whether or not, or how fast you can get a treatment past the FDA, right? And so those are things that you can't really necessarily solve on a state level or even on a city level. Perhaps you could focus much more on prevention there, or on better healthcare. But are there actually things that, if we, let's say, picked a state, or or let's say we even picked San Francisco, and we're okay, we're going to make you the role model of this new kind of almost like a charter city, San Francisco. We're going to try to implement the Singaporean model. How would that even look like? Because I think many of the things kind of need to be done at the national level, right? Because that's just where the funding and where the where the administration is. So I'd love to hear from you guys. What, if anything, can be ported to a city level?
I don't think it's necessarily a good one, for us to focus on, but especially things that have to do with, behavior, or, like when we, in New York, when we like banned sodas that were a certain size, obviously that has to do with diet, but there are things like that that can be done at the state level that could impact, obesity and aging. Again, I don't think that's particularly too on target for what we're doing, but it's an example of things that can affect health that can be done at the state level.
I would like to interject one other point based on, I touched on this a week ago, but it's more relevant now that we have Singapore experts here. I had a conversation with John Wong, who, this was 2018, and he was then the head of national NUHS, National University of Singapore Health System, I think. It oversees like 10 hospitals. And I asked him, where do they stand on the debate in the US on whether aging is a disease, and how does that affect regulatory approval of products that can extend health span or lifespan? And he said, well, we sidestep that debate. We think it's an unproductive debate. And what we focus on is there a marker that can predict the risk of disease? And is there a therapeutic that can reduce the risk of disease? If that's the case, then we're interested in promoting that to help our aging population. It's just obvious that aging is a risk factor for every disease, but we're practical. What therapeutics and what diagnostics can support smart intervention that can extend health span and reduce risk of disease? So I thought that was really productive. And maybe in our own community, we want to think, maybe we should debate less the question of, is aging a disease, and focus more on what can we do that's more practical than that.
I'm going to actually say something to this, because I think this is actually the biggest problem we have. And it sounds like such a simple answer, but we already have these markers. These markers are blood pressure and blood glucose. And we already label these as hypertension and diabetes. And we already treat these with drugs and drugs that just don't work, frankly. And so this entire model is flawed from the start, because health is so much more complicated than simple biomarkers. Although these markers are useful, they're not, we've labeled them as disease states, and we haven't looked at them as markers of a body that's failing to adapt to its environment. So I think you're both correct, but also you're not totally right, because this entire framework of thought has led us into the direction we're in right now.
Yeah, can I comment on that? I think that there's a new generation of biomarkers out there that are trying to measure biologic age, and I would not argue with you that they're validated yet, but I think that they're much more multifaceted measures and using AI. And our hope is that, aging is a much bigger risk factor than high glucose for almost any disease of aging, including diabetes. And our hope is that if we can accurately measure biologic age, then we can have a much better metric to determine whether interventions are affecting health span. And one of the things we're doing now, there's a lot of exercise programs and community-based programs in Singapore, and we're starting to interface with them so that we can put these biologic measures into lifestyle modification programs that already exist, and see if we can see an impact of these programs. And so I think that's one way we can implement connecting interventions with markers, and I mean newer markers of aging, and to see ultimately, I think it can cross-validate both the interventions and the markers. But it's still early days with these biomarkers, but I think they show a lot of promise.
Yeah, there's actually there's a bunch of epigenetic clocks that people are now designing out of things like Horvath clock. I mean, they're useful, but I actually think we already know the answers to all this. We actually understand that there are many hallmarks of aging, and it's likely, I personally believe, that most of them are downstream to mitochondrial dysfunction. And it seems like metabolic diseases that cause 80% of diseases in most of the world are largely related to the way we've designed our societies. And Singapore, it looks to me, has designed their society in a way that enhances mitochondrial function fundamentally, which is part of why I think they're living so long, along with the fact that everyone's pretty wealthy.
Question. Does anyone know what the process for getting regulatory approval is like in Singapore? Like, there's a drug I found a few weeks ago called nicurgoline or nicurgoline, or however you pronounced it. It was discovered many decades ago, and there are a bunch of studies. There's actually a meta-review by Cochrane showing that it's effective at treating some of the symptoms of dementia, but it's not approved in the US. You know, apparently no one has gone through all of the hoops needed to get it approved. So what would getting that approved look like, you know, assuming you have studies to say, okay, yeah, this actually works?
The simple version is Singapore is a small place, so mostly they leverage off the work that the U.S. and EU and China do. So if it's approved in one of these areas, then there can be a sort of kind of transfer application to get it approved in the Singapore market, and that's I think how most of the drugs are coming in, because it's just hard to get those kinds of the large scale studies that you would need to do. Like if Singapore were to do that independently, like you're saying that if you were to say it's not going to get done in the U.S. or I assume EU, right? If you take away those markets, and then how do you get it approved? Like say outside of those markets, I think that would be pretty difficult.
Yeah, and I don't know specifically about that drug, but I think this is a fundamental problem in medical care is that, you know, it's these phase 3 trials are huge. They cost a lot of money. And if you look at off-patent drugs that you're trying to repurpose, there's really very little way to get them funded to look at a new disease indication. And that's a big limiting factor, because I do think there's a lot of opportunity in repurposing. People know about metformin and rapamycin in the context of aging, but you know, the metformin trial that Nir Barzilai is trying to do is a $60 million trial, you know, and we got a drug that costs 4 cents a day. So, you know, it's been extremely hard to get that funded. And I think that's a challenge with repurposing drugs, not just in aging, but in many contexts. Singapore just doesn't have the size to do these huge trials, particularly if you're talking about more rare diseases.
Can I ask a question?
Sorry, go ahead.
Yeah, I just wanted to ask, so if we're talking about Singapore being, you know, an example of success in terms of their attitude towards aging, what are the quantitative markers of that? How is their spending on aging research on translation, you know, percentage-wise? I don't know, Brian, if you can comment on that, that would be great. Oh, and then to follow up, if they're like really awesome, how did that happen? Who told them that, you know, this is what they need to be focusing their attention on, and not like dietary interventions or whatever?
Well, you know, right now they've set aside a lot of money for aging research, but they haven't spent much of it. And for the last few years, they've been thinking really hard about, you know, what are we going to do? And they've engaged a whole range of different aspects of government. So you have people in some aspects of the government saying we just need to put roofs on all the sidewalks so that we can get the older people out so they can move around more and not get heat stroke. It's hot here. And, you know, and then you have other groups that really want to do cutting edge research. Some people that want to focus specifically on frailty. So I think the government still hasn't, they've been doing things related to aging in the community for a long time. But now that they're thinking about this research approach, they're still struggling with where to make the big commitments. And
do you know how they had the idea to invest in aging research or the related areas? Like what can we do to learn from that experience so that that pool of money, it was created so somebody made that decision, right?
Yeah, I think there's much more flexibility moving around in how they spend money on research. So they have 5-year strategies. It sounds a bit communist, but it's not. But every 5 years they come up with a new plan for how they're going to dedicate research spending. And so that seems to never happen in the US. You know, you have these entrenched research mechanisms and they tinker around the edges a little bit when Alzheimer's, you know, makes everybody afraid. They put more money into that, but they really don't change how the pie's cut that much. And so I think it's just a lack of responsiveness. I think a lot of people in the US, even in the NIH now, would say that aging is a big factor in all these diseases and we're not spending enough money on it. But how reconfigure that pie is a really big problem, whereas Singapore is, I think, more flexible, partly because of their size. They're more flexible in that regard.
I'm just going to jump in here because we are engaging with different groups in Singapore to get their thoughts on regulatory approval. The agency there is the HSA, Health Science Authority. It's analogous to the FDA. And when you look, you can check it out online, and it's structured in many ways like the FDA. They focus on therapeutics, not drugs. That's a different, or not devices. That's a different group. But what's really different, and we invited Dean Ho, who's a fellow nanomedical scientist. He's very closely involved with the HSA and knows a lot about it. So in a follow-up meeting, we should have Dean Ho join us. But what he says is that even though many of the same regulations apply in Singapore as apply in the US, the groups that are approving this, like everything else in Singapore, it's a smaller group and it's very tightly integrated with the science, with the university system and the health system. So there's a very small group that pretty much runs everything in Singapore, and that includes the regulatory authority. So if you have good science and key people at the university and the health system are behind you, you can go through the regulatory process much faster than you can in the US. And that, even if it ends up costing the same for us, time is money, that makes it really attractive. So.
All right. Thank you. I do want to say that we're now at 7:07 here at least. So I just want to, in case anyone has to drop off, want to thank you, from on the official end, and just say thank you so much for joining. I think that, I think talking about it without really having much context, it's really easy to be quite hopeful that a few magic tricks can just be ported. And I think, appreciating that the situation on the ground is actually quite complex and that there's a lot of different factors that play into that, I think is really helpful. So thank you for that. If you do have to hop off, Shazib, Brian, or Swaine, I do want to give you the last chance to say anything. But if you're able to stay longer, we're just going to continue this. But I just wanted to do a time check on this time.
Yeah, I'm gonna have to drop off here. So but this has been great. Really thank you for the opportunity to join this conversation. Hopefully,
thank you,
could do this again sometime.
Thank you so much for joining.
Yeah,
Thank you very much.
Wonderful.
I'll be disconnecting in about 10 minutes. Thank you very much to see everybody, and thanks Lou, and thanks yourself for inviting us.
Thank you. Shazib.
Thank you. I really appreciate it. Brian, how about you?
I can stay for another 10 minutes or so as well. So.
Okay, good. Then let's see what we can squeeze into the last 10-minute bits. And Luis, I just wanted to kind of pick up the thread that you mentioned, and you mentioned it last week, and you mentioned it also just now again, of the strategy in Singapore was actually a little bit different. Maybe they didn't just hone in right from the start on that aging angle, which is, here I think many of in our community are very concerned about trying to kind of get the right type of language or at least the right type of markers for aging and instantiated within an institutional setting in the US. But you basically said, well, they kind of just shortcut the whole thing and just said, well, whatever can kind of lower the risk of diseases will do, and there's a very big overlap with what we already care about with aging. Is there an advantage to that strategy, or is there something that we couldn't do with that strategy? So why are we not trying to do that strategy? Because I think, Molly said, well, there are a lot of aging clocks already out there, but I think maybe even getting them instantiated is harder. So is there a specific strategy for, are there specific treatments or focus areas that can only be pushed under the aging angle that could not be pushed under the risk angle that Singapore approached?
I'll just make one quick comment there, which is one of the advantages of focusing on aging as a risk factor is it's a single factor that then drives multiple diseases. And that's useful from an intellectual standpoint to understand the common roots of disease. But from the perspective of Dr. Wong at the NUHS, his attitude was, yeah, but that then you can deconstruct aging into specific markers, especially these new markers that are being developed with AI, and specific therapeutics that address what's happening at a molecular level that is potentially applicable to multiple diseases. So first, let's deconstruct the idea that one drug goes to one disease. That's a totally outdated concept. It's time to toss that. And I think a lot of people would support that idea because systems biology is making it really clear. There are specific molecules that drive or enable multiple diseases. So that I feel like they're at least 5 minutes ahead of us with that insight, and they're putting that into practice. That feels attainable. That feels like something we could win at in this country.
I actually love everything you said right there because it's so true. When you really look at the top leading causes of disease in our country, I once made a list of all of the predisposing factors, all the risk factors, and the same risk factors for dementia, cancer, heart disease, and diabetes. They're almost all the same.
Yeah.
And it's like, okay, so if you start looking at the body as a house and you start really thinking first principles and you think about like how America treats its houses and how Singapore is, like Singapore is making sure that the house is monitored. It's making sure that it has enough electricity running through it. It's making sure that it has an alarm system that works. And like our country's like, whatever, it's your house, deal with it, you know? Like we're like, well, you know, maybe there's energy or maybe there isn't. I mean, we're seeing the same macro, you know, problems like brownouts happening on the micro level in the human body in America. And it's like, we have this massive metabolic disease system that just is unfortunately not being well treated with the current medicines that we have. So I think like Singapore has fixed the way it's designed society. It's fundamentally different than America. And the way that people actually monitor its citizens is probably part of it. So I'm curious to know more about what it meant to monitor the elderly during the outbreak. Like, what did that actually entail? Was that contact tracing? Was that testing? Was it making sure they had food? Like, what did they do differently with the elderly that we didn't do?
I think that there's a stronger family bond here, so that it's still something of a Chinese system where you have the younger people in a family taking care of the elders. Often the elders live with them. There's less reliance on nursing homes here, and so that keeps in a lockdown situation, that keeps older people from being congregated together. And I think there's just generally a better responsiveness toward taking care of the needs of people as they age in this society. In some ways it goes too far. I mean, you know, we have a longitudinal program to look at people healthy over the age of 85 and compare them to the rest of the population. And, you know, when you get older here, you sort of relinquish decision-making. This is more of a Chinese thing than a Singapore thing. You relinquish decision-making back to your sons and daughters. And so we've had a lot of people say, oh, I want to participate in the program. And then we get a call from the son saying, you're not letting my dad do that. And so I think that on the one hand, there's a lot of monitoring, which is good, so that nobody is like falling through the cracks in a situation like this. But I'm not sure that many Americans want to let their kids make all their decisions for them when they get to 80 years old either. So there's some differences too. But, you know, there are other things here too, like, you know, it's extremely safe. You know, the society has been well organized. You don't have to worry about your 85-year-old grandparent walking out on the street in the middle of the night if that's what they want to do. They're not going to get a crime happen to them. You know, and other little things like we have a thunderstorm here every 5 minutes, and the other day I'm like, my power never goes out. And then I realized, well, of course they put all the electricity underground, you know, so we don't have, you know, those kinds of disruptions in service. And so I think that what the biggest problem in the U.S. is the politics has become totally reactionary. And people can't think more than 2 months ahead. And here you look at a society where they've actually identified problems now and in the future and developed long-term strategies to try to deal with them. And I'm hoping that aging can be effectively dealt with here using a similar approach.
I'd like to insert a question here for Shazib about redox medicine. You mentioned earlier that you were involved in that, and I'd like to know, given that redox effects are one of the primary manifestations of functional mitochondria, whether or not that approach is being used currently in Singapore medicine.
We are still at the experimental level, so we haven't really aggressively introduced it to the point of therapeutics. But the realization is there, as I think Dr. Molly also mentioned, that a lot of it is at mitochondrial dysfunction. And the mitochondrial dysfunction happens to have differences in redox metabolism of the mitochondria. So mitochondrial hormesis is something that has been, in terms of aging, has been very closely linked to whether there is a small level of mitochondrial ROS that is very important for normal functioning and for health. But if you exacerbate it, you end up in pathological states and mitochondrial dysfunction. So in terms of therapeutics, I don't think we are there yet.
How about the consumer connection to redox-sensitive nutrients like selenium, vitamin C, vitamin D, vitamin E, vitamin A?
Yeah, so you saw in the comments, I mean, there are a lot of natural products that are openly available here from GNC or natural foods, and people do consume a lot of these. Some are judicially used and some out of that too, but I think, yes, people use
Is that a minority of the people, or is that a popular thing?
Well, I won't know the numbers, but I think these are some of the things that you can purchase. And then there are a lot of the Chinese traditional medicine places where they also sell natural products that have natural antioxidant or redox modifying activity. So I think a lot of the Chinese population do take one or the other. So they do have these traditional Chinese medicine aside from the classical Western medication.
Yeah, TCM and to a lesser extent Ayurveda are very popular here, and there are a lot of natural products and extracts that potentially have effects on redox metabolism. So,
right. Thank you. I think as you have to hop off, perhaps in your final words, it would be amazing if you could say what, if anything, could be learned by the US from the Singaporean model. Is there one thing that you want to leave people here with, or do you actually think, oh well, maybe what we should just do instead is use Singapore as a test bed and actually move more companies out there if they're trying to do a specific thing, and then import the learnings later on? Like what would you think is something that may actually be useful here?
Well, maybe if it's okay, Shazib, I'll go first. I think it's interesting right now because there's this dichotomy. There's a lot of private sector investment in aging now, and that's happening mostly in the US and to some extent in Europe, and not really happening in terms of as much here in Singapore, although there are some initiatives. A lot of the venture capital in Singapore is targeted toward technology that has a fast turnaround. So there's not a lot of drug development, investment, that sort of thing. And so, the US and Europe is doing that well, but they're not taking care of the population very well. And they're not really focused on preventative medicine, particularly in the US. Whereas Singapore has much better community-based strategies for healthy aging, and there are a lot of ideas for investment here that I think that need to get access to funds so that we can develop them here, and maybe in a mindset that's more based on community development. So, to finding ways to reimbursement strategies or funding mechanisms that would allow us to develop things that may already exist that can't, go through the standard drug development strategies. So I think we both have a lot to learn from each other's, and there's deficiencies on both sides. It's not just on the US side. But on the US side, I just think if there's any way to get more of a progressive mindset to healthcare, you can see what the effects of that are in places like Singapore.
Yeah, I would just like to add maybe also, perhaps, I'm hopeful because I think the fact that we are here and talking about it, I guess the realization is there globally that this is an area that we need to invest in. I think, as Brian mentioned, we should complement perhaps what's happening in Europe and US in terms of the research and the funding, and what's happening in terms of the society model for taking care of the elderly population and putting those things in place. It's very difficult to do that, as people mentioned, things that we can do here or we have seen happen in Singapore in terms of people's compliance, people accepting the fact that somebody will be checking on their electricity or is working or not. Some of us in the US maybe, or some of you in the US or in Europe may not like the government to be dropping on you and then checking on. And so that there is a difference in that. So your house may be run down, but you won't allow people to interfere and tell you what to do. But having said that, there are things that we can learn. And I still believe that in the US, with all the massive research infrastructure and others, the healthcare providers probably could start from grounds up and then try to teach their policymakers.
Okay, Luis, do you have any last words as well?
No, I just want to thank our Singapore guests. It's really wonderful they made the time for this, and I hope this won't be the last time we can check in on what we can learn and how both countries are progressing and learning from each other.
I just wanted to echo Luis and thanking you all. Thank you so much for joining. I think if there's one thing that to be taken away from this is that it's kind of messy. It's also a little bit like a chicken and egg problem. It has to do a lot with culture, I think, with what people are already comfortable with. Some of the things we may not even want to port over here. And so I'm hoping that perhaps we can share a few links to, like, I know, Luis, you already shared one of the links in here, and perhaps I'll do a follow sweep up on anything that was discussed here. So thank you so much for joining. I really, really, really appreciate it. I'm hoping that we can try to advance on this more international connections. I'm hoping that next time perhaps we have Margareta here to learn from other from the models that work well in other countries, and that maybe we can build a web of knowledge that way. And I'll definitely look into more of what can be ported to a state or even city level after this. So thank you so much. It was very, very useful. Okay. Thank you, everyone. I'm going to open up breakout rooms afterwards now for those who still want to stay on. And I'm hoping that I'll see many of you again here next week. Next week, we have Sarah Constantine here, who will talk about specific things that we could be pushing for, like very specific treatment, focusing on immunosenescence that we could fast forward after COVID-19.